Folks, we're going to do something amazing. We're going to make a podcast about research about general practice. We're going to call it Hot Topics. You say someone has already done it? I'll do it better. Many people have told me. We can make it exciting, interesting, and mostly fictional. Don't worry about evidence-based medicine. It'll be exactly what they always wanted. I'll do the same to it as we did to the world economy. It's Friday, the 11th of April, and this is the Hot Topics podcast.
Welcome to the Hot Topics podcast from MB Medical. Great to be back with you. Neal Tucker here, as usual, taking you through some of the latest research relevant to us in general practice. So we've got 3 new papers to talk about today. In fact, the main event is an interview with one of the authors of these papers, Steve Bradley. So he's been part of a team just publishing a paper in the BJGP examining the link between rates of chest X-ray use in general practice and lung cancer staging and mortality. Before that, we've got 2 other new papers. First, we're looking at a BMJ paper looking at orthostatic hypertension. Yes, you heard me right, hypertension. Is this the new thing that we need to worry about? And then second, a paper in the Lancet on overactive bladder in women and the role of urodynamic studies. But before we get into that, we've got some NB news. So spring has definitely sprung. We've been blessed with lots of lovely sunny weather over the last few days. What felt like a really long, dark, dank winter is finally over. And to brighten your day even more, we currently have an offer on the NB Plus annual subscription until the 28th of April. So you get £25 off, making it just £332. For a whole year, you can join us for all of our live webinars. You can see all of our courses on demand as well, loads more besides, including all the reference books to all of the courses that we do online. Is an utter bargain. So just check that out if you're not already signed up to NB Plus. Given the fact that Donald Trump has crashed the world economy this week and no one knows what on earth is going to happen next, an NB Plus subscription could be the most reliable way to invest your money at the moment. We've probably all heard enough about the world economy in the news this week, so I'm not going to go into that in any more detail. This is a podcast about medical research relevant to primary care. So should we crack on with the research? And we're going to kick off with this paper in the BMJ. So this has the title, Effects of Intensive Blood Pressure Treatment on Orthostatic Hypertension, Individual Level Meta-Analysis. And this one caught my eye because I initially misread the title. So my cognitive biases kicked in and I thought it said about the effects of orthostatic hypotension. Turns out that authors have already published a meta-analysis on exactly that. And apparently they found that intensive blood pressure lowering actually decreases the risk of orthostatic hypotension, a finding so unlikely that the authors even acknowledge our findings may seem at odds with clinical experience. No kidding. Apparently, orthostatic hypotension may be an acute effect of antihypertensive treatment, but over the longer term, the body, perhaps the key here is another sentence that the authors put in the discussion of that paper, which states that intensive blood pressure treatment regimes do not increase the risk for orthostatic hypotension in most patients. Most patients is the key there. So I think there's a good chance that Doris, in her 80s, barely walking about her house, she's got diabetes, heart failure, frailty. She probably wasn't included in any of those studies that were looked at in their meta-analysis. And if you whack her on intensive blood pressure lowering therapy, she'll probably be in orthopedics with a fractured neck of fever before you can say, perhaps the indapamide was one step too far. Anyway, I've already digressed significantly because that's about orthostatic hypotension. They published that in 2020. We're talking about orthostatic hypertension. And to be honest, I did wonder, is this even a problem? Why have none of us ever considered this before? That's the grand none of us, because maybe it's just me that have never considered this before, but I don't see it turning up on a lot of patient notes. Well, apparently, postural hypertension is an emerging risk factor for several adverse health outcomes, principally cardiovascular disease and stroke, but also renal disease and cognitive impairment. Now, I've always thought that your blood pressure should go up a little bit when you stand up, but orthostatic hypertension is a more exaggerated response, which they define as a standing systolic blood pressure of at least 140 and a change of at least 20 millimeters of mercury systolic when you actually stand up. And just to be clear, I think that's meant to be from supine rather than sitting. Now, the question that this paper is answering is not whether postural hypertension is bad. As we've already said, it's been established that it may be a risk factor for a number of issues, but it's asking the question what effect intensive blood pressure lowering has on it. So they included adults with hypertension recruited to a number of different randomized controlled trials in which they were randomized to either more or less intensive blood pressure lowering regimes, which provided data not just on the typical sitting blood pressure readings, which is what most of the research looks at, but also on standing blood pressures. 31,000 patients and 315,000 standing blood pressures were recorded. 8% of that population had postural hypotension, but a much greater 17% demonstrated postural hypertension. Those patients that were on more intensive blood pressure lowering regimes, they had a slight reduction in the occurrence of orthostatic hypertension. But is knowing someone has postural hypertension, is going and looking for postural hypertension really worth it? In this meta-analysis, they've used patients that were in studies that specifically recruited people with elevated blood pressures. And in fact, the mean seated blood pressure of the participants was 153 systolic. So they've already got high blood pressure. Realistically, they're going to go on some antihypertensive treatment. Knowing about orthostatic hypertension isn't going to change that treatment regime, and good news that standard treatments may well address that problem anyway. To be honest, I feel like the whole issue is a bit of a moot point. I can't see us ever routinely checking standing blood pressures in our patients, as if we don't have enough to do already. But perhaps patients with home monitors and a lot of time on their hands could be a good way of keeping them busy. Continuing with the theme of not doing things that don't really help, let's think about our second paper, which was published in the Lancet last week. This was titled Invasive Urodynamic Investigations in the Management of Women with Refractory Overactive Bladder Symptoms in the UK, the FUTURE trial. I'm not quite sure where they got that acronym from there, but some of you will be able to figure that out, I'm sure. So this was an interesting study. It's a UK-based randomized controlled trial, and the question that they wanted to answer was whether women with refractory overactive bladder symptoms had better outcomes by adding in urodynamic testing to a comprehensive clinical assessment. So you're a woman with an overactive bladder, you've tried bladder retraining, you've tried some anticholinergics, maybe myrbetriq. It's not worked. The next step is to get a referral to the specialist, maybe be considered for Botox. But first, you're going to have an assessment to check whether we've got the right diagnosis and whether there's any other reasons why the treatments that we've tried already have failed. So you go and have a nice chat, and then they stick a tube up your urethra, they stick a tube up your backside, and they inflate you with water. I've always thought that the urodynamic tests sound absolutely horrendous. According to the paper, some studies have shown this to be a well-accepted investigation. Frankly, it's a hard pass from me unless it's really necessary. And as the results of this study show, it turns out it isn't. So they recruited 1,100 women with refractory overactive bladder or urgency predominant mixed urinary incontinence who had failed conservative management and were being considered for invasive treatment. And they were randomly assigned to either have a comprehensive clinical assessment or a comprehensive clinical assessment plus urodynamic studies. The primary outcome was patient-reported success at 15 months after randomization. And the data was very clear. It showed no difference between the two groups. So it doesn't matter whether you have urodynamics or you simply have a much nicer comprehensive clinical assessment, the outcomes were the same. Interestingly, urodynamics did change the diagnosis in around 13% of women, and that basically translated into fewer women having Botox. So the vast majority of women in the trial ended up ultimately having Botox to the bladder, but about 12% less had it if they'd had urodynamics in addition to that comprehensive clinical assessment. But regardless, it didn't lead to better patient-reported outcomes, and it was way off being cost effective. So off the back of this data, which was funded by the UK's National Institute for Health and Care Research, it's likely that pathways for women with refractory overactive bladders are going to change. We're likely to see urodynamic studies being dropped for the vast majority. So that's going to be better for women having unnecessary, unpleasant investigation, big cost savings to health service as well. This is a really good piece of research that definitely changes practice. On to our third paper then, and this is another piece of research that might well influence your practice. So published in the BJGP recently, this is titled General Practice Chest X-ray Rate is Associated with Earlier Lung Cancer Diagnosis and Reduced All-Cause Mortality. The title does a pretty good job of setting our expectations here. And I'm lucky enough today to be joined by the lead author, Dr. Stephen Bradley, who's here to have a chat with us about the paper in a little bit more detail. Hi there, Steve. How are you doing today?
Hello, Neil. I'm grand. Thank you. And thank you very much for having me on the podcast.
My pleasure. So just for our listeners who maybe aren't familiar with you, would you mind doing some quick introductions for yourself?
Yeah, certainly. So I'm a GP working in Leeds, and I'm also a researcher. I do work on cancer diagnosis, and I'm currently working at the University of Sheffield.
And you're here today to talk about your new paper. So just published, this is published in the BJGP, and this is all about the role of chest x-rays in general practice and how that affects lung cancer diagnosis. So firstly, the staging, but also looking at mortality as well. So maybe could you just give us a little bit of background about why this research needed to be done?
Yeah, certainly. So this research, firstly, I'd just like to mention, which was funded by Cancer Research UK. This research is really important because lung cancer is our leading cause of cancer death. It's our third most common non-skin cancer, but it's because outcomes are poor. It's the leading cause of cancer death, and actually leading cause of cancer death worldwide. And the presenting symptoms are often common, non-specific symptoms, the kinds of symptoms that we see in general practice all the time. And the main tool we've been using for this is the chest x-ray, which has been around for a long time. But there's been a lot of discussion about whether chest x-ray is up to the job, how useful chest x-ray is for diagnosing lung cancer, but it's what we have. So this research was really aiming to look at whether if we could do more chest x-rays in general practice, that would lead to earlier diagnosis and better outcomes for patients.
I mean, earlier diagnosis is the key here, isn't it? And I think maybe we tend to think about lung cancer as a disease that inevitably is going to kill someone. But actually, in early stage lung cancer, the survival outcomes are actually pretty good. And I was surprised. I actually looked at Cancer Research UK stats on this, and it shows if you have stage 1 lung cancer, your 5-year survival rate is actually 65%. I mean, I still prefer not to have it, but those odds are much better than I would have associated with lung cancer. But I guess the reality is that a lot of lung cancers are being diagnosed stage 3, stage 4, when you're starting to get more extensive lymph node involvement or spread well beyond the chest. And then, of course, the prognosis is really dire. For stage 4, it's a 5% 5-year survival, which is obviously absolutely terrible. So there's obviously a drive to try and bring the diagnosis earlier so we can catch it at an earlier stage, and then it may well be curable. So tell us then, what was the key aim of the study?
This is on the background of other research that's looked at referrals for urgent suspected cancer. Clinics used to be called 2-week waits, that have shown that practices that refer more often, their patients do better. that gives us a bit of encouragement maybe to use these pathways. But there's still need to steward that resource really quite carefully. We don't want to put patients through urgent suspected cancer appointments unnecessarily. We're still going to be really quite careful to make sure that patients meet the eligibility for those. Whereas chest x-ray is a more basic test and a test we can be more relaxed with. And if we know that it does help patients by doing it more often, then that can steer us to use the test more often in the hope that more patients will benefit from it.
How did you go about getting the information then? How did you conduct the study?
So we use data from the National Cancer Registry, and we use data from what's called the Diagnostic Imaging Dataset, which has basically counts of all the x-rays done at a general practice level, and the x-rays that were requested by the general practices themselves. And then we also used information from general practice profiles, that really great website that has loads of demographic and other information about general practices. And we put them all together in a linked data set, and we broke up practices based on how frequently they were using chest x-ray, and then looked at the outcomes, the cancer outcomes, and that was really at what stage the disease was diagnosed and the survival of those patients at 1 and 5 years.
Okay, so we're essentially kind of comparing levels of chest x-ray counts within GP practices against rates of cancer, the stage of cancer diagnosis, and then ultimately the survival of those patients as well. Okay, so what were the key results then?
So we found that practices in the highest quintile of use, those patients who had lung cancer who had registered those practices were more likely to be diagnosed with early stage disease, so that's stage 1 or 2, and that was an odds ratio of 0.87. And also they were more likely to survive to 5 years, so that was a hazard ratio of 0.95, favouring survival to 5 years.
So what do you think then, Steve? I mean, this is important research. So this shows us that in those practices that do use more chest x-rays, you are more likely to diagnose lung cancer at an earlier stage, and your patients are more likely to survive. Are we basically saying that it would be better to do more chest x-rays in general practice?
Yeah, with some caution, because this could become absurd if we just said everybody should just do more and more.
Yeah.
And you can end up with a sort of Tony Blair argument around what everybody has to be better than average. Obviously that would not make sense. But I think how we can make this a bit more sensible is reflecting on how often we are using chest x-ray, and if we feel we're using it less often than other practices, or not always taking advantage of the opportunity when patients mention things like a cough or other symptoms, particularly if they're a smoker, during other consultations or other reasons why they've come, then we should take up that opportunity to use chest x-ray where we can. It would become absurd if we all just did tons and tons and tons of x-rays all the time for no good reason. But there's a reasonable amount of variation in how much practices are using chest x-ray, and we know that isn't really accounted for by the types of patients, by age, by smoking status, by comorbidity. So some practices are using chest x-ray quite a bit less. Particularly for those practices, it could be an opportunity to consider using the test more often.
So it seems, as well as maybe reflecting on our own individual practice, we could actually go and look at how our GP practices as a whole is doing, and if we're seeing that marked variation, and maybe we are a bit of an outlier compared with other practices, then that could be something that we could address.
Yeah. And what would really help here, and something we've been calling for some years, is for this data, which is held by Diagnostic Imaging Dataset, to be put on GP practice profiles so that we could see this. At the minute, there's not any really easy way for practices or primary care networks or integrated care boards to look at this data to find out, to triangulate where we are in terms of how much we're using this really important, really high frequency test. But that data should be available. It should be out there. That data is recorded for other things like endoscopy, which is a less frequently used test, and in my opinion, probably less useful to know about for practices. So it would be really great to see this data being made available, which is already being collected by Diagnostic Imaging Dataset, and we should be able to use it to support our quality of care.
I mean, you've already cautioned people on just sort of unfettered use of chest X-rays, and I guess maybe what that's sort of suggesting is we're getting into the realm of screening. And of course, we've had data that shows that lung cancer screening with chest X-rays doesn't seem to work in the UK, but we also have now a targeted lung cancer screening program, which does have quite favourable results. Your data, of course, was taken from before the introduction of that targeted lung cancer screening program. So does the introduction of that have any implications for the impact of the findings of this paper?
The context of screening is really important because I think there is a tendency to hope that lung cancer is no longer our problem in general practice because this screening program, which is really welcome, the hope would be that this will identify all our patients who have lung cancer. In fact, for the foreseeable future, most patients are still going to present via symptoms to general practices. And that's because only about half of people who have lung cancer would have been eligible for lung cancer screening, and only about half of people who are invited for lung cancer screening actually participate. I think the findings are still relevant. I think they would only not be relevant if we thought that lung cancer screening was going to effectively solve the problem of lung cancer, which it won't. It will help, and it's really important and really welcome, but it won't solve this problem. And just to go back just about the issue of using chest X-rays, and you said about unfettered access, and I suppose in a way I am relaxed about unfettered access, and we have self-request services in Leeds and Manchester where patients can access this test themselves, and it's been shown that patients are using that test in the right way, and the conversion rates to cancer is broadly similar to what we see in general practice. I suppose what I was indicating was it would be ridiculous to say we should just do chest X-rays indiscriminately. Clearly, we need to think about the symptoms that patients come with. And if you look at the NICE criteria, the NICE NG12 criteria, it's really salutary, I think, to have a look at this occasionally because it's such a broad range of symptoms that qualifies you for an urgent chest X-ray. So cough, shortness of breath, chest pain, raised platelet counts. There's a number there. So chest X-ray is a useful test for a lot of patients who come to see us with symptoms. We do need to bear in mind that it's not a perfect test, and also a lot of the patients who come to see us with these kinds of symptoms may not have lung cancer, but they may have other important conditions as well.
I mean, you alluded to this earlier in the chat, but obviously there's limitations of chest X-rays, and I think most of us would appreciate that a CT chest is a better tool, but the reality is that we don't have good access to that. There's not enough CT scanners in the country, so we have to work with what we've got.
Yeah, absolutely. And the real conundrum here is that CT would be the perfect test, but the most common symptoms that people come with who have lung cancer are really common symptoms in general, like cough, and the risk of those people individually having lung cancer is really quite low, so around 1% or less. So it's quite difficult to justify all of those people having a CT scan. For some of them it will be, and that's where our intuition and decision making comes into play, and we can advocate for that person to get a CT if we're concerned, even though there's been a normal chest X-ray. But doing CT for all of those patients would be really difficult. And just to give you some of the numbers, it's pretty incredible. GPs in England request almost 2 million chest X-rays a year. It's an incredible number. And some colleagues in Leeds have looked at what proportion of that would be, of those X-rays would meet the NG12 criteria. And just looking at the text that GPs put on the clinical information box, which, you know, is never the whole story. There's always other symptoms other than that. But just looking at those, about a third of that 2 million chest X-rays would qualify for the NG12 criteria. It's possible that some of these patients do warrant a CT chest, and we're doing some research now to look at whether different pathways should be used in the future, like low-dose CT for some of these patients. But the suggestion that all these patients should just get a CT is just not tenable at at the minute, really, in terms of the volume of radiology capacity that we have.
We're going to need a lot more scanners in Tesco if we want to meet that demand, I think, aren't we? One last question for you then, Steve. I think some of the listeners may feel that a reason not to be doing more CTs is because they have concerns about overdiagnosis. There's been a growing recognition for this problem. And I guess this is complex here. You do obviously mention it in the paper. I'm guessing you don't get many non-serious lung cancers. I guess you might be picking up nodules that ultimately are benign, but still require follow-up, kind of scare the bejeebers out of patients whilst they're undergoing that, or indeed it may require patients to go on and have biopsy of some sort, which is then quite an invasive and potentially dangerous procedure. So could you take anything about the potential for overdiagnosis from the information that you got?
Well, overdiagnosis is an issue. And one of the advantages, I suppose, of chest X-ray is it doesn't pick up these really tiny nodules, which we see on CT and can lead to cascade of surveillance. Even so, we shouldn't dismiss entirely the possibility that people could end up having a chest X-ray, which could lead to a CT, which could lead to other things, other investigations, and that patient may not benefit, that is what overdiagnosis is, diagnosis that doesn't really benefit. But chest X-ray is less concerning in that regard than CT is. All tests do have potential harms. In this situation, I think the severity of the disease and the dreadful outcomes that we've historically had for lung cancer do justify using this test. I think the take home here for GPs is just how we think about chest X-ray. I think historically we've been pessimistic about lung cancer in general. Patients do benefit from early diagnosis for lung cancer, and increasingly so. We've got new therapies which are more and more effective. And even those patients who won't do as well, it's still better for them to be diagnosed in general through an orderly process rather than being diagnosed through the emergency room, which is very traumatic. The radiation associated with it is very, very low. It's equivalent of background radiation in the environment for a few days. And people can be in and out of walk-in chest X-ray units really quickly. It's also pretty cheap to do, and we can do a lot more chest X-rays than we can do with CTs. So it is a useful test, and we need to do what we can to pick up this disease as early as possible.
Steve, thanks so much for joining us on the podcast today and chatting through your research with us. Let's hope this maybe changes some practice a little bit. So thanks a lot for coming.
Thanks so much, Neil. And if you don't mind, I'd just like to say a few thank yous as well, if that's okay, just for this research. So firstly, thanks to Cancer Research UK who funded this, to my wonderful PhD supervisors. This was done initially as a PhD project, even though my PhD finished a few years ago. Richard Neal, Beth Jenkins, Matt Callister, and Willie Hamilton. Also to others who are involved in this paper, particularly some really heavy-duty statistical input from Matt Barkley, who is the supervising author, and Gary Abel. Thank you very much to all of those colleagues.
Sounds like a really big team effort there. Brilliant. Thank you, Steve. Well, I hope you've enjoyed the podcast today. Don't forget that NB Plus offer running until the 28th of April. If you're not already signed up, then get on it now. Remember, you can always get in touch on hot topics at nbmedical.com. And I hope you have a great Easter. I hope you don't have to work too hard. Well, at least no harder than usual. And I hope you get some sunshine. We'll be back in 4 weeks' time with the next podcast. Until then, take care. Bye-bye.